So I think I'm going to start trying to find the slides. We're going to go for country alphabetic number, except for Malaysia. And we call this session overview of country experiences. Many of you have been authors of some of the initial country reports for LTC COVID. Some of you have joined later, and you're really welcome. And I'll just find the slides. We have another similar session tomorrow afternoon where people from the Americas will not have to get up as early, and that will be better suited to our timeline, so do join them tomorrow as well. So I will find the slides. And this is a bit like a rapid fire session. We have in theory 3 slides per country. We might have a few more for 1 or 2. Happen sometimes. And we're going to try and be strict to staying at 6 minutes per presentation so that we have a bit of time for discussion. It's a long session. I understand some of you may want to go and meet and get a coffee. Oscar, is your hand, do you have something else you'd like to say, or is it a historic hand?
Yeah, I forgot to.
Oh, no worries. Okay, thank you. Okay, so I think we're pretty much ready to speak. I see Kai, who from Austria, who is the first person, is already here, thankfully. So thank you, Kai. And yeah, let's get started. Thank you.
Yeah, thank you. So this will be a very rapid sprint through the Austrian long-term care system, and especially one specificity of this system. Next slide, please. The overview that was asked shows that Austria went relatively well during the first wave, then got hit quite hard also during the second wave, also in care homes, with 43–44% of deaths only in care homes. Then vaccination started, and nevertheless, because of several issues, now we are in the 4th wave with world record numbers. And unfortunately, this has also again entered the long-term care sector. Not as much as before, but still we are there again because of breakthroughs and other things, and unvaccinated staff, I would mainly say. Yeah, next slide, please. We have, of course, regionally regional differences there, but I would like to focus on the live-in migrant carers in Austria, which are a specificity of this system. We had an exceptional growth of migrant live-in carers over the past 2 decades, also due to some legal regulations, but still there is to put it positive, there's a fragile balance of rights, precarious working conditions, and the quality of care. And also here, of course, the pandemic showed the issues. We have, on the one hand, some subsidies for clients and regulations regarding competencies of these live-in migrant carers, mainly from Czech Republic, Romania, and Hungary, that work mainly as self-employed personal carers and work in bi-weekly, or now also more and more in 3 monthly shifts. And there, of course, we have working time issues. We have issues in particular then during the pandemic, when the borders are closed. Next slide, please. So during the pandemic, there were these travel restrictions. There was the isolation in private homes, which is already an issue also during non-lockdowns. We are currently again in a lockdown, but with still open borders. so this isolation is ongoing, and we have still the self-employed that are registered with the Chamber of Commerce. It got some public attention during the pandemic, but there is no substantial debate or reform, although this model, according to me, is something that has a kind of an expiry date. Next slide, please. Because what we see already in Czech Republic, Slovak Republic, there are trends that wages are, so the wage differentials between these countries and Austria are reducing, and we see already since several years that now it is mainly Romanian migrant carers in Austria that are now more than Slovaks that were first in the leading position. We also see in the European context, for example, the German Federal Labor Court sentenced that 24-hour care means an entitlement for 24 hours of minimum wage. And if this is the case, then this model will also have some difficulties. I mentioned already, with exceptional pay rises and also developing long-term care systems in the neighboring countries, there will be difficulties to recruit also in this area. Next slide. I think this is just an overview. Adelina showed already that there are resources around. We contributed over the past months also in updating this information. If you want to read more about the long-term care system in Austria in general and about this specificity of the 24-hour carers, please have a look. Thank you very much. I hope this was 6 minutes.
Actually, it was perfect. Thank you very much, Kai. It was absolutely perfect. And one more. Right, so now we're moving to the Czech Republic, and delighted to welcome, and I don't know if I pronounce your name well, Petr Wija from Czech Republic. Are you ready, Petr?
Yes, hello.
Hello.
Hello to everybody. Nice to see you. And congratulations to great work. It really is very helpful and very growing. And so it's nice, it's very informal and good, very good platform. So thank you. And I don't know if you have my presentation, first slide. This is first slide. No. Hello.
Adelina, you're muted.
So I can't, it doesn't seem to be on the deck, and I was wondering, Chanel, if do you have it to hand ready to bring up?
I'm not too sure I received it.
Okay, so Petr, would you be able to share it yourself? Do you think we can give you a minute or two? One thing we can do is we can move to England in the meantime to give you some time to find it. And Nina, if you're ready, we're going to come to you. And that way, Petr, we can just find your slide. If you, we'll just have a quick look to see if we can bring it up. Thank you. So Nina, are you able to come in, speak about England?
Yes, that should be fine. Can you hear me okay? Because my computer's playing up a little. Can be a bit fuzzy.
We can hear you.
Okay, fabulous. Thank you. Let me just pull up my notes. Great. Okay. So lovely to join you all. My name is Nina Hemmings. I'm a researcher at the Nuffield Trust, which is a think tank based in London. I'll be talking about England today. So if we could go on to the next slide, please, Adeline. And the next one. Thank you. Oh, I think some of the content might not have carried through, but let's go ahead and see what comes up. So just a quick note to say that some of what I present has been drawn on some research that we've been carrying out with Adelina's team at LSE, which looks to investigate the recovery and resilience of social care in England during the pandemic, and it was funded by NIHR. So next slide, please. Thank you. So a lot of content to cover in 6 minutes, and I want to do justice to this, but essentially in terms of an overview of the impact of the pandemic on people who draw on social care services and who work in social care. I've clustered up these different impacts by groups of people. We'll just provide a quick overview. So at the start of today's conference, Trevor mentioned the importance of carers. And evidence suggests that not only has the number of carers grown since the pandemic began to an estimated 4.5 million carers, the pressures on them have also been really significant, with an estimated 1 in 4 who can't cover their monthly expenses. Thinking about people drawing on social care, we know from data in 2020 that there were 20,000 deaths between March and June of that year, and 40% of those were COVID-related deaths. And that proportion did shrink to 26% the next year between October to February, but there were still a further 16,355 deaths among people using services in care homes. Thank you. There seems to be a bit of a data or evidence gap regarding people drawing on home care services, and this is something we'd be really interested in hearing from other countries about, in terms of the extent of your understanding of how people using home care have been affected. This seems to be a particular problem in terms of our understanding in England that we could do more on. And I'll touch quickly on the formal workforce. So, as others have mentioned, they have seen considerable challenges. We know that there were 922 deaths by May 2021 of this year. The workforce are also experiencing severe burnout, and sickness absence rates have doubled. Some of our more recent research by colleagues at Nuffield Trust has suggested that there were 42,000 fewer staff between spring and autumn of this year. And we are also seeing some interesting trends in terms of occupancy rates in the market. So a 12 to 13% drop among non-specialist care homes compared to 2019 before the pandemic began. So let's move on to the next slide, please, Adelina. Thank you. Sorry, I think some of the material has shifted around, but I'll push on. So our research is still ongoing, but our work and the work of others does point to a number of existing weaknesses in the social care system, which influenced the national response and affected the ability of the sector to respond to the pandemic. So essentially, the sector entered the pandemic in a fragile state, and we heard that the crisis was precipitated by some of those weaknesses that you can see on the left-hand side. Thank you, Adelina, for scrolling down. And some of these include a fragile provider market, various workforce challenges, including poor recruitment and retention, and poor working terms and conditions, and issues of innovation, where we have pockets where we can identify them, but they're not always scaled and spread comprehensively. And so from these existing weaknesses, we've identified a number of priority areas or themes where we heard that England needs to learn important lessons. And we've grouped these into the categories of system, people, and resources. And we think that ultimately these were key factors in affecting the coordination and the timeliness of the response, and ultimately shaped the impact of the pandemic on the sector. So for example, on the theme of accountability, it wasn't always sufficiently clear who or which organisations were responsible for different aspects of the response. So this lack of clarity, for example, over responsibility for PPE created delays and confusion. And as Paula pointed out at the start of the conference, we also heard that there were opportunities to prepare the sector for a pandemic that had been missed over the years. Just conscious of time, so I'll move on to the last box there, which is about some areas of the response that were stronger. So we heard that some lessons had been learnt and implemented by the time of the second outbreak, with, for example, an improvement in collaboration between the Department of Health and Social Care and other social care partners on issues like rolling out vaccinations among people or using home care services, as well as improvements in data collection, which may be helping to provide the foundations for a more robust source of standard data in the future. Next slide, please, Adeline. Thank you. So lastly, I'd just like to reflect on some key reforms and notable policy measures that have been introduced to date. This timeline isn't comprehensive or to scale actually, but it shows a snapshot of more recent measures, both in terms of direct policy responses to the pandemic. So for example, the extension of funding for things like hospital discharge and helping people to recover back in their own homes in the community, as well as the policy to make COVID-19 vaccinations mandatory for staff back in November of this year. I've also included a note on the Health and Social Care Levy, which is a policy response intended to reform the system and reform specifically the way it's funded, as well as a couple of measures which we think might be in the pipeline in the future for next year. So things like the extension of free PPE for the sector. I'm conscious of time, so perhaps I will leave it there unless I've got any more minutes, Adeline.
Adeline, you're on mute.
Yeah.
Oh, okay, so I couldn't find the mute button
that.
when I'm sharing. Yes, very quickly, Nina, please.
Oh, great. Just to say that I'd like to reflect that while the Department of Health and Social Care in England has recently put out a white paper which sets out a wider vision for the long term for social care reform, many are quite concerned that it doesn't go far enough or that it doesn't meet the specific challenges we're seeing ahead of this winter. On the flip hand, we've also heard many views that the pandemic has shifted the national debate, with a real focus now on social care in the public and political eye. So there is a real opportunity to have a more open discussion about what a person-led vision of social care could look like. Thank you.
Thank you very much. And here's Nina's email if you have any further thoughts. And now we're going to move to France, and here's someone else also from the Nuffield we're collaborating with. So Camille, all yours.
Thanks very much, Adelina. So hi everyone, it's really lovely to be here with you all. So as Adelina said, I'm Camille Oung, and like Nina, I'm a researcher at the Nuffield Trust, and we've been working with Adelina and others on the Social Care Recovery and Resilience project. So I'm going to be presenting a very quick overview of what happened in France during the pandemic, and I should say that these thoughts are going to be really high level, and I'm going to whiz through them as fast as possible, but we will be looking to complete them over coming months, as we've chosen France as one of our case studies. So if anybody is interested in kind of getting in touch and discussing these further, I'd be very interested to hear your thoughts. Next slide, please. Thank you. So turning first to the impact of COVID-19 on the French long-term care system, I'll touch on kind of three key issues. So I think it would be fair to say that in the first waves of the pandemic, there were significant impacts on people who draw on care and people who provide it. So physical and mental health deteriorated for users of care, following care arrangements breaking down, limited alternative support being in place, as well as the impact of isolation. And there were concerns among quite a number of different stakeholders in France that people were losing abilities to undertake activities of daily living, and there were some reports that some users of care were also denied access to acute services. Sadly, a high number of deaths were recorded, in care homes especially, but less is known about the impact at home on users of home care as well as unpaid carers. And as you can see from the slide, so over the first wave of the pandemic, almost half of COVID deaths occurred in care home settings. And as of the most recent update of this month, that's almost now 27,000 people who've sadly died. And so the French long-term care system went into the pandemic with chronic workforce shortages and as well limited levels of protection during the pandemic for staff, meant that high levels of staff sickness were recorded as well as some deaths. And this led to even greater staff shortages and many care staff taking on very complex caring activities, such as providing care at the end of life in the absence of doctors and nurses to support with that. France has also chosen to introduce mandatory vaccination for all health and care staff since this September. And it's probably too early to understand the impact on the sector sustainability and on workforce perspectives on work and care. There are also significant issues around the value of the care sector in France related to health services. So compared to health, there were delays in producing guidance for the sector, especially around home care. There were delays in accessing PPE and other medical support, and that's estimated to have contributed to high levels of death in care homes and perhaps in other settings too. And there was limited integration with healthcare services, for example, around primary care. And so that contributed as well to the physical and mental health impacts on care users, which I described earlier. If you could move to the next slide, please, Adelina. Thank you very much. So in terms of lessons that need to be learnt in terms of the response in France, I think the French care system went into the pandemic following several years of delayed reform, so it had limited preparedness to manage crises such as a pandemic. And an example of that neglect in the care sector was that there was no Minister of Care between 2017 and 2020, and that was reintroduced in 2020, somewhat prompted by the pandemic. At a regional and local level, there is significant fragmentation of the sector with complex accountability arrangements. So, for example, different financing and governance arrangements between care homes and domiciliary care. So this also created delays and confusion, especially at the beginning of the pandemic, for example, in organising access to PPE and testing. I've already referred to some of the impacts on staff as well, but the conditions for staff going into the pandemic and limited support during created high numbers of shortages. In recognition of this, however, most staff have been paid quite significant COVID bonuses, so up to 1,500 euros in care homes, although this has varied across the country and across types of care provided. There is also some promising learning around measures introduced during the pandemic. So, for example, the deployment of mobile rapid response teams focused on geriatric and palliative care, the rollout of named GPs for long-term care facilities, and also reimagined relationships between care homes and domiciliary care services, and an attempt to make care homes more connected to their local areas. Next slide, please, Adelina. So looking now towards reform, so this is really where I wanted to focus on the most. So I think one of the key changes to the care system in France that happened following last summer was that there was a large sector-wide consultation which was undertaken with key stakeholders across health and social care to build recovery and resilience into health and care systems as a result of the pandemic. And so I just thought I'd touch on some of these key changes because I think they're quite interesting and perhaps have some interesting learning, especially as they get embedded. So firstly, in order to kind of improve that transparency at a decentralized level, increased decision-making has been given to regional structures as well as local authorities, and as well as improvements to local authority structures which provide support to older and disabled people. So really to kind of foster that transparency at more regional and local levels. And given the challenges in staffing, it was recognised that care careers need to be made much more attractive and much better working conditions for workers. So this has led to significant increases in pay. So in domiciliary care, up to 13 to 15% increases based on experience. In care homes, staff will be paid an additional 183 euros per month. And there are also increased training places for nursing And in France, it's quite interesting because there are roles for domiciliary care nurses. There has also been an ambition to create some stability, especially around the home care sector, with the ambition to kind of move to more provision in home care. So there's been a minimum hourly rate for home care, which has been introduced at 22 euros per hour, with the potential to get an additional 3 euros per hour for providers who can demonstrate improvement. So that might be whether investing in staff training, improving in infrastructure and quality of care, looking to develop new innovations, etc. So the idea really here to stabilize the sector and drive innovation. However, there are questions about whether the funding will be enough to allow this. And then finally, I think something which is really interesting as well is there's been some major investments into the infrastructure of care home estates. So to prepare care homes for the future, so whether that's to prepare for future outbreaks, but also the impacts of changing climate conditions, and the ambition also to create new models for care homes which are more embedded within local communities. So some significant funding has been afforded to make structural improvements to existing care homes, as well as creating new care homes, which are more responsive to people's needs and wants, and also with an increased link to health services as well. And other funds have also been allocated to support digital and IT development, also in recognition of the kind of challenges during the pandemic of the existing IT infrastructure in care homes. And just to finally touch on a major development which will be happening over the next few years. So a 5th pillar of social security is being developed around long-term care. So we would hope to see increased access and protection around high costs in coming years. So yeah, just to conclude, I hope I haven't rushed through that too quickly, but this is all very early days for some of these measures for reform. So it'll be interesting to see how they play out and whether they'll be sufficient to protect the sector against current and future waves of the pandemic, as well as other shocks, and how this is all embedded within approaching elections too. So thank you very much. If you want to read any more of these details, you're very welcome to have a look at what's on the French country profile. Thank you very much. I think you're still on mute, Adelina.
If I unmute, it's very helpful. I would think that by this stage, I'd be mastering that after almost 2 years. So thank you very much, Camille. And we're now going to move to Iceland. And I'm delighted that we have Þórdís, Hulda, Tómasdóttir, I don't know if I pronounced that well, and Ólafur, Samúelsson. Thank you so much for joining us. And if you're ready.
Yes, thank you. Thank you.
Thank you.
Yeah, my name is Þórdís Tómasdóttir. I'm the nurse manager at Hjúkrunarheimili, and Ólafur, our doctor, is also here. But as we only got 6 minutes, we decided that I would speak. So if you just run the slides, please. Right, I was just going to talk about the lessons learned in during the pandemic in Iceland regarding our NH residents. I can see that we have similar challenges as England in regards to, you know, we are underfunded and our workers are often not educated ones. So next slide, please. It's just an overview of the pandemic. As you can see that, the population of Iceland is 365,000 over 103 square kilometers. And around 4.5% of those of Icelanders live in long-term care, and it's financed by taxes. As you can see on this slide, the total number of deaths has been 29 until now, which is, you also have to think about, because we're only 365,000, so that's quite a lot of us. So if you put the next slide on, and what you can see is the death as proportion of infection is quite high among those 70 to over 90 years old. That is the most of our COVID deaths have been in this that age groups. So it's 194% that have had infections in 80 years and older, and of them have been 20 deaths. So it's only 9 deaths that are not in this age category. So if you put the next slide on. Our response was quite interesting. perhaps. We are a very small country, so, and we only have one hospital that is, well, one national hospital. So, and what we did is that it was quite obvious from the beginning that nursing homes were incapable of handling an outbreak on their own, both, could you say, physically, but as well as mentally. We had all this information coming from abroad, and we were just terrified. So the Ministry of Health and the Directorate of Health, the chief epidemiologist, and doctors and nurses specializing in geriatrics formed a consultation group on nursing homes issues and daycare centers during the pandemic. So it was kind of a national initiative. So we had guidelines issued with alert criteria. So the criteria would be according to which wave was going on, pandemic waves. And in those guidelines, we had employee checklist restrictions. So it would be both restrictions for visitation and access to the nursing homes. We had chapters on infection prevention measures, first response, how to isolate, how to quarantine, who to quarantine. And it would also include risk assessment and transmission tracing, treatment and post-infection guidelines. So, but the thing is that we are 365,000 people, over 103 square kilometers, and half of us live in Reykjavik area. So every single nursing home and daycare center, they worked through the national guidelines. So it kind of didn't matter if it was a nursing home in a really small nursing home in the northeast of the country that hadn't seen COVID, they all locked down. We all did the same thing. So this is kind of what we've learned since then. Now in what we call the fifth wave, is that now people are more empowered to make their own decisions, but based on the national guidelines. So this group met once a week, and then we had once a month a meeting with all relative players all around the country. But in addition to that, we put on suspenders as well as the belt. So the Directorate of Health and the Chief Epidemiologist and the Department of Civil Protection and Emergency Management launched what we call the Swot Team. So that was kind of a team of 5 specialists. So if you put on the next slide, just turn on the enter code, yeah, and again, sorry. So that was kind of a team of 5 specialists. There was instant response via our 112 or 911 call. So it kind of said that if an infection has or might have entered the premises, what do we do? So this is what we did in order to empower each institution by their own, and kind of made them, you know, self-assured enough to handle things on their own. And this we did via Zoom or Teams meetings with everyone involved. So we had actually courses online for almost 600 people all around the country in order to do that. So the next slide as well. So we also did, because we have quite a limited hospital capacity during COVID-19. We have we don't have enough ICU beds, and some of course, our residents were not candidates for any ICU treatment anyway. So what we did is we formed a joint COVID-19 isolation ward for nursing home residents. So an association of companies in welfare services and the Icelandic Health Insurance and us at Eir Nursing Home, we opened a joint isolation ward for those residents of nursing homes that would need isolation. If you put the next slide on as well. So as you can see, we had the capacity to take 10 to 12 COVID infected nursing home residents, and we could isolate them all together. And what we found out is, well, we believe that at least some of our patients, they were patients by that point, would actually have died isolated alone in a room in a hospital. But we had them all together. So we had, yeah, there you can see the together. No, next slide. Yeah, we had a table where we all ate. Well, they all ate together. We had a sitting room, and we kind of, our isolation was then meant to be as normal as possible, if you can say that, because people, at least those that do not have any kind of dementia, were actually terrified of COVID and were just so absolutely sure that they would die. And I think, believe that some of our patients would actually have died out of fright and anxiety than perhaps more than COVID related issues. So this is what we did in Iceland. And if you turn on the next, put enter, please, yeah. And actually tomorrow we are opening an isolation ward for the elderly that do not need specialized hospitalization but cannot isolate at home. So tomorrow it's not just long-term care residents, but all those elderly that have some kind of issues with isolating at home will be able to come to us. And we can also see that at the current moment we have an outbreak at a nursing home where we have had 11 residents that have COVID-19 that we need to get out as soon as possible. And we can also see that almost 100,000 of our 306,000 have actually got the booster shot, and people are not getting as sick now as they did before. So this is actually what we learned. If you have the next slide as well, is isolate infected individual as soon as possible, quarantine those that have been exposed and quarantine them, in an orderly fashion, empower all the healthcare workers. So we can also, I can see that France would be something that it's admirable to look up to, because there is quite an incentive in getting a little bit more paid, which we have not done here. And it's a tangible multi-level support of everyone that is necessary, and the cooperation. And kind of what we are trying to do in nursing homes is also to try to keep the joy of the co-workers still, but it's really hard. We can feel that people are getting quite tired of the situation, but hopefully we'll get there. So I can see that we have a lot to learn from each and every one of you. So thank you.
Thank you very much, Þórdís, and that's a really fantastic picture, I have to say. Thank you. So we're now moving to Italy, and I'm delighted that Eleonora Perobelli is joining us. And all yours, Eleonora.
Thank you, and good morning, everyone. I am Eleonora Perobelli from the Observatory on Long-Term Care from Bocconi University in Milan. So if you can go to the next slide, please. Yeah, just as the other colleagues, I will briefly go on the impact of the pandemic on the Italian long-term care system, then see what's the legacy of the pandemic for the system, and I will briefly show you what's coming next with some major European funds for the system. So next slide, please. So we split the impact of the pandemic on the long-term care system into, I have to say that Italy has 21 regions, and regions are the ones that manage long-term care system. So we have basically 21 different long-term care systems. So it's really difficult to give you a comprehensive overview. And the second thing that is a major issue for Italy is that we have no official data on the impact of the pandemic on the long-term care system as a whole. So not in nursing homes, not in home care. So it's it's really a major weakness of the system, and it's really embarrassing to present data on Italy with respect to what other countries have done, but that's just what we have. So what we observed in the first wave, which was really hard for Italy, that was one of the hardest hit countries in the world, is that we had a lot of...
1 second, Eleonora, it's become a bit faint. Are you able to get a little bit closer to the mic?
Yes, sorry, can you hear me better now?
I think so, thank you.
Okay, thank you, sorry. So what we observed in the first wave is that there was no coordination at all between long-term care settings and other settings, other care settings, and long-term care sector was not prioritized for PPE equipment. So it was really hard for services to cope with the emergency. We do know from a survey from the Ministry of Health that the mortality rate in nursing homes for older adults was around 3.1%. What we also do know is that the NHS during the first wave hired a lot of nurses and a lot of doctors to cope with the pandemic in hospitals, and most of this staff was coming from long-term care services. So I mean, there was a lot of a huge shortage of personnel in long-term care services, which added the emergence to the other emergence. So it was really, really hard for the services. Next slide, please. So after the first wave, we had a second, third, and we are currently experiencing the first wave, and we are still lacking comprehensive data on the sector, but we have guidelines that were prompted by regions to promote better coordination between long-term care settings and specialized COVID care centers. A good lessons learned, I would say, is that now long-term care services are prioritized both in terms of PPE supply and in terms of vaccination campaigns. So residents and workforce working in nursing homes specifically were the first groups to receive vaccine, and it's actually now mandatory for the work staff in nursing homes to get a vaccine. So this was a strong policy intervention back in January 2021, and we are still lacking a plan to increase the long-term care workforce. And so service providers are really struggling with the shortage of personnel in services. So next slide, please. Just to show you really quickly the impact of the vaccination campaign. So you can see the red line shows you the number of cases in the general population, whereas the blue line, the one that is in the lower part of the graph, shows you the number of cases among nursing homes residents. And you can see that after the vaccination campaign, we had a sharp drop in new cases in nursing homes. And the same goes for what we can see in the next slide, please. That is related to the distribution of deaths. So here we are only observing the deaths by type in nursing homes for older adults. And as you can see, the number of deaths related to COVID-19, which is the red line, that is again in the lower part of the graph, decreased quite sharply after the beginning of the vaccination campaign. So just to show you what happened in nursing homes. Next slide, please. As concerns what we've learned, as for England, I mean, the long-term care system from Italy was quite weak also before the pandemic, and now is extremely weak after the pandemic. We learned that the long-term care services need to be better coordinated with the other care settings, and regions are now working to promote protocols and guidelines to manage the topic. We are also lacking, the estimates say 60,000 nurses in long-term care services. So it's something, I mean, it's just impossible to manage in the short term and maybe also in the medium term. So we are trying to understand how to tackle the issue at the national level. The service providers are facing major economic sustainability issues. And so here again, just as in other countries, we require public intervention that was lacking. So we had no national funding to help service provider to tackle the economic sustainability issue, but also we need some business model innovation. Fourth, after 20 years, also in Italy, we are convinced by home care as a response to long-term care needs. So everyone is talking about home care, but we're still lacking a comprehensive response and proposal on how to deliver home care at the national level. So, but at least we're talking about it. So I would say it's a result. And last, we do require some proper official data at the national level that should guide both policymakers in their decision and also to help everyone to assess policies and also to ensure accountability, which was lacking throughout the pandemic. Next slide, please. So as concerns the what's next, here I'm just pointing out something that is really major for us because Italy is among the largest beneficiaries from the Next Generation EU program from the European Commission, and the government in April 2021 launched the National Recovery Plan for Resilience, and this plan merges multiple sources of funding for a total of almost 250 billion euros. So it's something extraordinary for us, and it concerns every area of the economy. So the plan mentions a lot of investments in home care and community care, but it does not express the how because it's a strategic plan. And so we are all waiting for the guidelines I mean, they should come in early 2022 to understand how to allocate these resources, who should be entitled for managing the resources, and who are going to be the stakeholders involved. So we are in a phase of great expectations, and hopefully we'll reform the system. And thank you for your attention and for the great event.
Thank you very much, Eleonora. And now we're going to move to Malta, and I think we've got Maria Aurora Fenech. Are you ready, Maria Aurora?
Yes, I'm here. So apologies for this, sorry. Can you hear me?
We can hear you, but we can also hear someone else.
Just a minute. Sorry about that. Because we're trying to share office space here.
Yeah,
home space
of working from home. So we all understand that very well.
Apologies for that. So I'm Maria. I'm from the University of Malta. I'm both a lecturer and researcher at the university. Next slide, please, Adelina. So for the sake of this presentation, let me initially try and give you a brief overview of how the situation stood and stands currently. So Malta was never in a lockdown, but care homes did go through a volitional lockdown for 12 weeks initially, some of the care homes, whilst others opted for a 1 to 3 week shift. So basically, all was well for these 12 weeks. There were no deaths recorded, and everything was fine. But then towards August, when we started having relaxation of measures, the virus started creeping into the care homes, mainly because whilst the older persons were still constrained within the care homes, yet staff after the 12-week lockdown were allowed to go in and resume their work schedules as pre-pandemic. However, relatives were not allowed inside the homes, and older persons were still stuck inside the homes. And So, and something which was very irritating and terrifying in a way, that at the end of February of this year, all older persons had received both vaccine shots, and yet they were still constrained within the care homes, and they were only allowed outside of the homes on the 15th June 2021. So basically they had spent 15 months in imposed lockdown. Next slide, please. So it's the impact of the pandemic now. So when I spoke, I had a snapshot and I spoke to a sample of care home managers from the private run, church run and government run care homes. So the general feel was that the private care home management had the idea during the 12-week lockdown that the policymaker was working towards an exit strategy, and that kind of thing, should there have been a crisis, everybody would have resorted to a policy plan. Unfortunately, when the crisis struck, there was no policy whatsoever. And the care homes, mostly the private care homes, resorted to what they had been working on for months. So basically, the extra costs incurred in overtime and in extra salaries for staff and for buying PPE equipment, everything they had to fork out themselves. And even during the interviews that I had with care home management, the general feel was of great frustration and anger. Even now, whilst preparing for this presentation, it's extremely awkward and embarrassing to say that I am not privy to the number of older persons who perished during the crisis. A very fair estimate would be, I would say, between 100 and 150 older persons, but that's a very, very rough guess, because even just before I entered for this workshop, and I tried again to get the data, but I did not manage. In total, 468 persons died from March 2020 until to date, and that's 99% of that number are 60 years and over. Next slide, please. So these are the lessons learned from the snapshot from the persons I spoke with. Incidentally, because I did not mention it, when I wanted to speak with the government care home management, I was not privy to being allowed to speak with the management per se. So I got the feedback from the policymaker. So kind of thing, it stands out a bit, because on one aspect, for the church run and for the private run, I did speak with the management per se. On the other side, on the government run, I did not. And that says a lot and warrants further looking into, I must say. So basically, and at long last, people were suddenly getting aware that our local care homes are too large in number. So we have care homes with 7 persons, mostly the church run, but then we have care homes mostly having 100 bedded units, 200, 300, 400, and the largest one has 1,400 older persons occupancy, which is humongous to say the least. And that caused quite a bit of problem because of infection and anything related to the pandemic. So management spoke of the isolation and the social isolation and the harm that it was causing the older persons. And incidentally, towards March, April of this year, I did manage to interview a sample of older persons residing in the care homes, and the anger which during the interviews and the emotion, it was so high at times, it was beyond control, having to continue with speaking with these older persons per se. So kind of thing, what the private sector is saying and what the older persons are relaying are very much in sync with what is actually going on. Can we go to the next slide, please? So when it came to reforms, and I was speaking about asking management to let me know about what reforms there will say, I've put the presentation into the green and into the blue. So the green is mostly the feedback from the private run care homes. The blue is from the government run care homes. And you can see a very unique distinction. So private care homes were frustrated and angry. They are working round the clock towards soul searching and upgrading their policies and operational procedures with respect to care models and providing care for the older person, but yet they were lamenting about the incestuous relationships in between different organizations. So basically they blamed it, and I tend to agree, on the small size of Malta, with a population of around 250,000, where everybody knows each other. And obviously it makes governance quite a bit tricky. With respect to the government model, they are reinforcing fines if private care homes and church-run homes do not manage to observe contractual obligations. They are still favoring relatives not entering the homes, even though to date all older persons have received their third shot. They're more ingrained into rewarding staff for holding on during the pandemic. Obviously, I mean, I don't condone this fact, but I think that the persons who really held on were the older persons who had to spend 15 months logged inside without having a voice whatsoever, and to reintroduce the isolation hospital. So during the crisis, between August and December of last year, when there was the real crisis within the care homes, government resorted to a public-private partnership with this isolation hospital, where infected older persons were relocated into this hospital. But from the interviews and from speaking with care home management, I gathered that those older persons who did manage to being discharged from this isolation hospital in one piece, mainly did so losing their activities of daily living and their mobility, and a good number of them were riddled with pressure areas. There was no audit to this isolation hospital, so I just leave it in your thoughts as to how it was being managed. So older persons spoke of having spent the entire 3-week period in confinement and bed-bound for the 3-week duration. They weren't even allowed out of bed, or as opposed to the model which our colleague from Iceland presented right here, where people ate around the table. It was nothing of this sort of thing. So basically, this is my overview for the presentation. I hope I stuck to my 6 minutes, Adelina.
I think so. Thank you so much.
Just before I leave, Adelina, just a personal thank you. Because even before we registered our first case, I was already hooked with what you were working on, and it really kept me on during the more disturbing months of the pandemic. Thanks so much.
Thank you very much, Aurora, and thanks also for giving us bringing so much to life the issues that we are dealing with. I really appreciate. Thank you. And we now are going to move to Poland, and now my colleague, so here are Aurora's contacts, by the way, and Aurora is also on the LTC COVID experts list. We're going to move to Poland, and my colleague from LSE, Joanna Marczak, is going to present. Thank you, Joanna.
Thank you very much, Adelina. So my name is Joanna Marczak, and I'm a researcher at the Care Policy and Evaluation Center at the LSE. And I'm going to try to be very brief in terms of giving you a very quick overview of the Polish experience with the pandemic. Next slide, Adelina, please. So in terms of the impact of the pandemic on the long-term care system, it similarly to some of my colleagues that spoke earlier, there is very limited data in terms of the absolute numbers of deaths in the long-term care system in Poland. We have actually requested some of the data from the Polish Statistical Office, and we're hoping to get it. But I don't have anything I could give you now. However, some of my colleagues who saw the data earlier have noted in different reports that in absolute numbers, in terms of deaths among the elderly in the long-term care facilities in Poland, these were quite low relative to other countries. But that was mostly due to the fact that most people in Poland with long-term care needs are cared by families and by informal carers. So the access to the formal long-term care in Poland is very, very limited. In terms of the pandemic, in terms of the pandemic per se, there was reported lack of access to community care as well as residential care, partly due to the fact that, for example, daycare centers closed, a lot of daycare centers closed during the pandemic, especially until the vaccination became available. There were fewer eligibility assessments carried out, so that all impacted access to the community care. But also residential care facilities didn't accept as many residents as they would normally because of the pandemic. And various reports highlight very limited access to medical care, both for residents of long-term care facilities, but in general by older people. So similarly, again, to some of my colleagues that spoke earlier, Polish long-term care is very, very decentralized and I would say quite chaotic. So there's some services provided by the healthcare sector, some of them are provided by the social care sector, and so social care sector, similarly to UK, every municipality, local authority is responsible for what it provides. So there was quite a lot of chaos in terms of, you know, how the different sector and different local authorities responded to the pandemic. In terms of other impact, there's been a lot of reports about specifically providers of residential care facilities facing financial shortages. This was partly because, for example, of increased PPE cost, which is not a surprise. However, it was also because of the increased food cost, which, to be honest, I was surprised about. And these shortages were partly addressed by the government, but partly by charities and also by private donations. So, for example, there were reports about private companies, but also private individuals donating not only PPE, but also donating food to the residential care facilities. So in general, the pandemic, I would say, had a strong negative impact on the long-term care. It highlighted what kind of was there before, which was very much underdeveloped sector. But if there was anything that was positive, it was that the pandemic actually drew attention for the first time to the people with long-term care needs, who were a bit kind of underground and far more invisible before the pandemic. Next slide, Adelina, please. So in terms of the lessons learned, so that very much linked to what I've already said. So the pandemic highlighted the problems which were ongoing. The pandemic kind of brought these to light, and obviously some new challenges. There was lack of pandemic preparedness, of course, so that's a lot of experts highlighted that wasn't really, that really hampered the response. Shortfalls in long-term care funding, workforce, similar again to other countries, and my colleagues who spoke earlier, Poland faced shortages of long-term care workers prior to pandemic, but it's been more visible during the pandemic. So, for example, even in 2016, the report highlighted that there were about 0.5 long-term care workers per 100 older people in Poland, where the EU average was 3.8. And that became even worse during the pandemic. A lack of training was also highlighted by the pandemic and low wages. In terms of the workforce, that's also to feed into what my colleagues talked earlier about the migrant workforce. So, Poland is one of these countries where actually Polish people go to the neighbor countries to work in long-term care sector, whereas we face our own shortages. We try to address them by kind of employing people from abroad, mostly from Ukraine, but obviously that doesn't cut the mustard. And also in terms of shortfalls in governance, so what I've already highlighted, the poor coordination between health and social care, but also poor regulation and quality control. Also among private providers, there's been very little known what happens in terms of the private providers of long-term care services. And that's been particularly problematic during the pandemic. Next slide, please. In terms of key reforms that are needed, and I just want to highlight here again, these are the reforms that that experts highlight again and again that they are needed. These are not necessarily reforms that the Polish government currently is envisioning or have any kind of concrete plans to address. But many experts highlighted, of course, the need for more funding, but also more access to long-term care services, particularly to community care, which is very limited in Poland, but also more support to informal carers. So not surprisingly, because of the lack of formal long-term care services, a lot of the care burden falls on unpaid informal carers in Poland. And I should have said earlier that although there isn't much data about what happened to unpaid carers during the pandemic, the very little data we have or information we have, it highlights what we expect to highlight. It's that the care burden for unpaid carers increased during the pandemic. So there is definitely a need to support informal carers more with various aspects, to combine employment with care, but also in terms of psychological support and training as well. Investment in workforce have been highlighted by numerous experts that that's something that needs to be addressed in terms of increase in wages, improvement of working condition, increasing the prestige of care work to draw more people to work in the sector, but also training. So, for example, in terms of pandemic, the need for technology became more visible, and the need to train the people in the care sector to use technology have become more visible. Improvement of the coordination, of course, that again has been highlighted numerously, but also including data coordination. So again, to kind of mirror some of what my colleagues said, there is very fragmented, not only limited data of what happens in the long-term care sector. The data is very fragmented. There are bits and pieces about the healthcare, about the social care, about the different municipalities, and it's very hard to draw kind of a unified picture of what's happening in long-term care because of that. Another thing that's been highlighted that's very important in terms of addressing was the better monitoring and quality management in long-term care institutions, and again, particularly in the private sector. And of course, that also includes getting data in terms of what's happening in the private sector. You can't really monitor anything if you don't know what's happening. So that's all I wanted to say about the Polish experience. But there is more information on the Polish report on the LTC COVID website, and there are links to further reports and resources Thank you very much.
And there's the mute button. Thank you very much, Joanna. Thank you. And now we're going to move back to the Czech Republic. So Petr, I think we are ready. I think Daisy is going to be sharing the screen. Yes, there she is, ready. And then we'll go to Malaysia afterwards.
Okay, can you hear me? It's fine.
Yes, thank you.
It's working fine. Okay, thank you again, Adelina, for your work. It's a great job. Thank you. It's a lot of sources to learn about the situation and measures in other countries. And next, first slide, please. So Czech, I have 3 slides as was asked us to do. So first is just generally, of course, it's very broad topic, but it's a very general picture that we have one of the highest death rate of COVID cumulative since the beginning. At the beginning in 2020, first wave, we were fine, but at the autumn 2020 and winter 2020-21 was a really big wave, and now we are facing also a very challenging situation because COVID units are full and emergency units are full, and there is lack of workers, and we have to postpone so-called elective care, which we think like it's preventive care, for screening for cancer, for example, or some operations in many hospitals had to be postponed due to COVID. So in the opposite, we had a low share of deaths in care homes because the reason is, I think, because at the beginning, the society was very united. But there was strong solidarity. They were making and producing face masks at home. There was really insecurity about what can happen, and there was strong commitment to the measures. So not many comparing other countries. I have resources at the bottom footnote. There is a link to sources I use in this presentation. Compared to other countries where the share of LTC users were higher. And the reason now is that, of course, care homes are prioritized in vaccination. I mean, both workers and both users. So now this big wave is not again about people in LTC seconds because they are fully vaccinated. I mean, they have 2 doses of vaccine. And now we are vaccinating people above 60 with 3rd dose. And yes, and but as you can see, there were long lockdown and many homes were locked with their staff in, and they lived together, and they reported it was a unique experience to cook, to live there, to bake, to share, you know, from day to night and sleep there, like really share environment, which they call its home. So there was home also for them. Of course, I think it's very similar. Please, next slide. Also similar as to the I think the previous one. Yes, that Similarly as to other countries, residential homes were closed, and there was lack of contact, social contacts, so it was isolation, not possible to visit physically these settings. So it was very frustrating, and then some homes invented how to protect, to how can meet safely. And other problem is low vaccination rate, because there is rising polarization and disinformation campaigns on social networks, on many fake news websites, and comparing to, as I told, to 2020, strong unity, solidarity, there are demonstrations and security, even attacks of health personnel who ask people at the COVID units, emergency units, if they are, for example, vaccinated, and that we have a strong group who denies the because of some arguments from fake news, like it's experimental and so on. And a lot of such fake news is supported from Russia and financed from Russia. And it's a secret intelligence report, so it's official source that it's so the situation now is big tensions, frustrations. Health workers who received thanks and support and gratefulness now face very angry patients and very angry people who are unvaccinated and who are in units. So as I said, following the discussion in neighboring Austria, we have discussing obligatory vaccination, but at the moment we don't have obligatory vaccination of people above 60. Even Vaccinological Medical Society is against obligatory vaccination of people above 60. And we have a long discussion that there are very different views and individualistic views of some so-called expert, which makes situation even more difficult whom to believe. And we don't have obligatory vaccination even for health and social services staff. It's not obligatory, it's still discussed, and I must say that at the beginning we had the similar challenges like with equipment and so on, and that Czech army was a significant help, and generally civic society, community volunteers who make shopping for people at homes, locked at homes, and so on and so on. So big initiatives, like in communities, in concrete cities, in concrete municipalities. So now we have people vaccinated, but we have in hospital people at 40 years in a critical situation who were not vaccinated. So now we have not sufficient capacity for vaccination of people above 60 who are waiting for third dose. So the final slide, please. I don't know, to summarize. I think giving current wave, which, as I said, we are after Hungary, one and Bulgaria and some other countries, the worst in the world in number of deaths per number of population in the world in deaths of COVID. So given the situation that people deny vaccination, even and therefore we see that this clear need for communication strategy, and we need training for emergencies, as was mentioned before, because it was really exceptional situation. There was no plans for how to deal with such situation. Now, how to deal with infection, how to deal with contacts and so on. So now I see that the biggest problem is compliance and trust, that really there is active fight against disinformation, because really people are believing it's organized from pharmaceutical industry, from United States, from I don't know what else, and they believe they want to be vaccinated, and so it's the reason why we have now gained full COVID units and emergency units, and as I said. And also I must agree with predecessors that it's a chronic problems is like underfinancing, especially lack of community services, which we can see that community services are better because there cannot be such spread of infection like in residential care. But as was said in other countries, still there is not in terms of financing priority for aging at home and staying at home. So of course problems between care and health. We have lack of big challenges now, as Kai also mentioned, this lack of workers, health workers generally in hospitals, because now they are really tired and frustrated after such a long time, and with lack of support from public contrast in the beginning. And so yes, it's very similar challenges and lack of personnel and poor working conditions and so on. It's I think the same in nearly all countries, with informal care being also kind of neglected, or didn't get enough attention, people who are at home or in informal care. So I hope I covered all important. I don't know how is my time if I speak too long.
No, that's okay. Thank you very much, Peter. And now we're going to move to Malaysia. And Maw-Pin, if you've got some slides and you're able to share them, that'd be great. If not, you can just speak without, as you prefer. Yes.
Yeah, you can see my slides.
Yeah, maybe you want to project them. Yeah,
sure. Okay, so thank you very much for giving me the opportunity to share this. So Malaysia is unique compared to the other countries that have shared, of course, because we are from Asia and we are a developing country in Asia, our population has not yet aged, so only 10% of the Malaysian population is aged 60 years and over today, but it's going to age very rapidly, with 2 million over 65 years today or last year, increasing to 6 million over 65 years in 2040. Unfortunately, even though we have relatively fewer older people, the dependency level of our older people is increased. It's not been measured accurately, but definitely when we've done a few studies, and comparatively, there's a higher level of disability in our population. So usually caregivers are informal female, caregiving is provided informally by female members of the family. But increasingly, we've started using paid caregivers, and they are very bipolar. There's those over-the-top trained nurses, highly experienced, who cost a lot, and that usually is funded out of pocket by people who have the affordability, or just for foreign domestic workers who are very lowly paid and potentially exploited with no training. And institutional care-wise, we estimate that 1% of our older population is actually, of our population over the age of 60 is actually in institutional care. So that's about 30,000 residents in total. So the COVID never really did much in Malaysia in 2020. And it was really hailed as a success story in how Malaysia actually handled COVID. But then when things went completely pear-shaped after the turn of the new year due to political instability and apparently the Delta variant. So we really saw the peak of our infections in end of August, early September time. But for Klang Valley, where many of our care homes are, the peak was actually in July. And it's been a really painful journey for all of us in Malaysia and lots of lessons learned. So it's really a story of two halves, success story in 2021, and then after October 2020, things started going wrong. So from March 2020, when we knew that basically COVID was in town from January, and there was a super spreader cluster in March. The care homes went into complete lockdown, and by April, there was already a national policy imposing COVID PCR testing for all discharges from hospitals prior to care homes. And so therefore, from until October 2020, we were really pleased with ourselves. There were only 4 documented care home outbreaks and a total of 6 deaths, despite none of our care homes having had any access to PPEs, because really they are for a care home that charges about $300 to $400 per month. Care home is actually PPEs are actually out of their reach. But then from October 2020 till September 2021, our data became unminable for a while, because initially they were reporting individual cases, so we could see the age and the comorbidities of every single case, because there were so few cases. And then they moved to reporting clusters, and we could identify that they were care home clusters because they would be indicated as such. And then after that, when the numbers went totally out of kilter, we had no data as to whether care home outbreaks were happening until we had a change in the Minister of Health, who insisted that raw data was deposited in GitHub. So we could actually then download all the data, raw data from GitHub. And the last time I did it, unfortunately, was September 2021. And we were able to identify care homes from high-risk clusters. We don't have the granular data as to how many of these high-risk people are from care homes, but we know that 5% of all outbreaks were on high-risk clusters, and high-risk clusters would include care homes, hospital clusters, private hospital clusters, not government hospital clusters, and also prisons and schools. So we know that prisons and schools will have a relatively low mortality rate. So and there, out of the 11,000 cases that were documented as from high-risk clusters, there were 381 deaths. So assuming nearly all the deaths happened in the care homes, then COVID-19 has actually led to the deaths of 1% of all our Malaysian care home residents. And this had happened because when the care homes started literally dropping like flies, there was no capacity in the hospitals. And so initially they had coped by starting this dedicated geriatric COVID facility. And we were already very upset that these facilities were not well equipped. There was not even an X-ray facility in the geriatric care facility. People were just sent there to actually be palliated. And when this geriatric facility became full, then we started caring for outbreaks in situ with no resources. And in one instance, 75% of the residents who caught COVID, which was nearly all the residents in that care home, actually died. And this all happened because while we had started our vaccination efforts in February 2020, our care homes were not really vaccinated till July 2021. Because of this early success story, people just assumed that this was all a hue and cry for nothing. Care homes were not really at risks. Let's not prioritize care home residents and staff for vaccination. So even though we had taken a lot of effort to collect names and addresses and of individuals in care homes registered and unregistered in February 2021 to pass them on to the authorities, there was no effort to actually go to these care homes to actually deliver vaccination as a priority, which has basically led to a bloodbath in Malaysian care homes. So a story of complacency. So thank you very much. And this is my email address if people would like more information.
Thank you very much, Maw-Pin, and thanks for reminding us how different the situation it is. We've heard a lot about Europe so far, and I really appreciate you bringing us such a different experience, and yeah, I understand how difficult it must have been to see all this as well. And we will hear from a few other countries later today. So we will have there is a session kindly organized by Peter Lloyd Sherlock that will be here from Mexico, South Africa, and Brazil. And then we have another very late on tonight, we will go to New Zealand for those of you who can stay. And tomorrow we have another similar session where we will have presentations from Canada, Germany, Israel, Mexico, and Norway so far. I may have room for one or two more. So if anybody wants to speak with me quickly, let me know via email. And now we have a few minutes left. I hope you're not too tired. We have about 10 minutes. And I noticed a couple of comments and questions in the chat, but I also want to encourage those of you who spoke, if you heard something from another country that caught your attention and that you want to ask about, then please feel free, just raise your hand and or put a comment in the chat. I'm going to pick a comment from Camille first, and maybe you, that's in the chat, you want to perhaps express it, because it's also something I thought while we were listening.
Thanks, Adelina. Yeah, it was just a thought really looking at all of the really interesting presentations about how many similarities, especially around the points of, areas of focus for reform that were so similar across several of the countries. I mean, Italy and France especially almost had the same final slide, and it was quite interesting to see, that the need for support to unpaid carers, the need to invest urgently into the workforce, the need for better data and monitoring across the care system, just under investment generally across long-term care systems, except for maybe Iceland, which had a kind of different approach. But it was really interesting to see all of those similarities. So, yeah.
Thank you. And I noticed a comment from Hulda Oung. If you want to make it, you can unmute yourself and turn the camera off for a moment, if you're still there. If not, I'll read it out. See if any of you would like to respond. So,
hello, thank you, Adelina.
Yeah, thank you.
Mine, I was just mainly basing it on my experience in this context. I'm in Kenya. So a lot of the responses, of policy responses on aging issues and long-term care nonetheless here are driven by advocacy or civil society action. So I wondered if the context of the presenters, whether that was impacted on during the COVID-19 pandemic, and whether it shifted kind of the debates that go on in those sectors from, yeah.
Thank you very much, Hulda. Would anybody like to respond? Feel free to just unmute and speak where. Yeah, thank you. And I can speak now as from the UK perspective. I think the media played a very important role, and I think also in other European countries. Quite often they were trying to develop their own tracking of what was happening in care homes, and I think that put on, at least in the UK context, a lot of political pressure, and you could see a relatively rapid response to some of the things that were highlighted through the press. So I don't know if there's any experiences of advocacy, successful advocacy in other countries. Also, if you haven't spoken and you're listening and you have a thought from your own country, please feel free to join as well.
Well, I can say that in Italy, the press impact was quite detrimental, I would say, because there was actually no call for data or to do something for nursing homes. Rather, it was really an accuse to nursing homes. So we know that in the first wave, nursing homes were without PPE, without workforce, completely isolated from other care settings. In Lombardy region, nursing homes became sort of COVID hospitals. So they were bringing people with COVID-19 in nursing homes without being able to isolating other people in nursing homes. So it was a total disaster. And so the press started to say nursing homes are just inadequate, are really dangerous for the safety of the population. So this actually was, there was a lot of framing of the evil of nursing homes. So that was, I would say, really bad impact of the press, at least in the first wave of the pandemic. And then I cannot say that we saw in major newspapers some sort of call for, I don't know, some advocacy for nursing homes.
Thank you very much, Eleonora. And anyone from any other country like to respond? And Ilaria, if this is a response to the same question, feel free to speak. If it's another question, then we'll hold off for a second.
No, can you hear me?
Yes, yes.
Yeah, thank you so much to have the chance to discuss on this topic, and especially thank you so much for Eleonora, because we are very close. We are in, I'm currently working in Switzerland, part of Italy, like Ticino, so we are very close, and you have stand out a very interesting consideration, and I think and hopefully we can be in contact with each others, because I think that we can share a lot of information. And also we are currently working regarding this part of Switzerland, so we are very interested to share also our consideration. I also working on quality studies regarding this topic, and just what we say, that it's a very similar consideration that Eleonora told to us. So thank you so much.
Thank you very much, Ilaria. I'm going, before going to Janice, I'm going to bring a question from Nina that's in the chat. Do you want to mention it, Nina, yourself?
Yeah, thanks, Adelina. It was about mandatory vaccinations, and Eleonora, you mentioned that Italy has strode ahead with this, and from April 2022, so next year, England will make vaccinations mandatory for all frontline health and social care staff. This has caused quite a lot of concern among some in the sector, so we'd be really keen to know what kind of impact has it had in Italy, both positive and negative, and any lessons you might have for us.
That's a really good question. I mean, I can only tell you what we saw at the general level, because we do not have official and comprehensive data. But again, on a general level, both the workforce and residents had a positive attitude towards vaccination, because most part of the population understood that protecting older residents in nursing homes was something that was just something we had to do. But in some regions in the north of Italy, there was major resistance from the workforce especially. So no issues among residents, but the workforce resisted quite a lot. But the government was really, I would say, really stick to its point, because the workforce was just suspended with no income in case they do not want to vaccinate. And this, of course, in the medium term led people to get a vaccine, because otherwise they were just without a job. And so I would say that now, as of today, almost 100% of the workforce and of the residents are vaccinated. And we are also administering now the third dose of the vaccine. And this is mandatory too for the workforce and for residents. So we are going really strong, I would say, with vaccination. And as of today, at least in the press, and from what we hear from other stakeholders, people just adjusted to the policy. And I mean, we have some exceptions with people that are complaining, of course, as it is normal, it is. But on a general level, people just adjusted, because otherwise they would have been left with no income. So that was an incentive.
Thank you. And Janice, you have your hand up.
Yeah, thanks very
you
much.
Put up very early, didn't you? You're from
yes,
Canada.
I've been listening while having coffee and breakfast here in Canada. One of the things that struck me, because we have a lot of similarities, especially with the workforce, and some provinces, of course, we have 13 different jurisdictions. So some provinces, like my province in Nova Scotia, they are mandating the vaccines similar to Italy, but others, our two largest provinces, Ontario and Quebec, are strongly encouraging it, but it's not mandated. So they're not, they were supposed to be by the end of November, but it's been delayed because of the human resource issues that we're experiencing. I just had a comment because there are a lot of similarities across the countries, but I may have missed it. It may have been a caffeine deficit, but I didn't hear about the physical plant of the facility, because that was certainly something that happened in our country, and particularly our province. We had one outbreak early on, devastating results, as many of you probably know, or maybe you don't. The first wave of all the people who died, 80% were residents in long-term care. We've gotten so much better with vaccines, but still, you know, the physical plant, the sharing of rooms, all of the other things you said, like lack of preparation, lack of support for long-term care, lack of recognition, lack of PPE, all of those things happened. But the other thing that happened was the difficulty in isolating individuals. So just wondered if that was also the case elsewhere. Thank you.
I'm going to actually invite Þórdís, because I was very struck by the image of this isolation. I don't know how you'd call it, but this approach to isolation and the contrast with what you were explaining from Malta, Maria, and I imagine it. I mean, in Malaysia must be also a completely different style of rooms. I mean, I haven't been to Malaysia, but I have visited care homes in India, where you have a large number of people in the same room. And obviously the idea of isolating is just a completely different concept. So just wonder, we have a few minutes, actually two, but just you want to quickly jump in and just comment, the three of you, on the layout of the care homes in your countries.
I'm from Malta. From what I understand from the pictures that older persons painted, older persons were confined in rooms, sharing 2 or 3 in a room. There was no TV, no dining table. They were confined in bed with bed restraints and everything, with the bedsides. And they were just visited every so often by a carer to drop them food and everything. But there were instances where older persons were so unwell that they couldn't eat, and the food was left there until the evening. So, I mean, obviously, I find it as no surprise then that older persons ended up with pressure sores. So having heard our colleague from Iceland and posting that picture there of that table where all older persons were, you know, kind of thing, all COVID positive, but yet eating together, it was certainly a breath of fresh air.
Maw-Pin, if you want to come in and
Yeah,
give us a visual, if you can display.
Well, Malaysia is really very, very heterogeneous. So we have got relatively luxurious care homes where, you know, people can have single rooms, 2 or 3 to a room. The environment's usually clean, but the main problem with those care homes is they are air conditioned. And so the ventilation can be very poor because they use these things called split level air conditioning. So then there's no ventilation whatsoever. And the funny thing is, the irony is, for the poorer care homes or the charitable homes or the government homes, you might have a large number of people in one room. The spacing, it's regulated, so it's not too crowded nowadays. But they don't have air conditioning, so the doors and windows are always open. So that was the reason why we thought that we were not so badly hit the first time. But when Delta came along, by the time we realized that COVID was in the facility, it had already spread. So, you know, we didn't have like small numbers. It was like 100% of the residents getting involved and the staff as well. So that was really very devastating because it just spread so fast as wildfire. So containment was no longer necessary. You know, it's like everybody's got it already. Yeah.
Thank you. And I don't see Þórdís. I don't know if she's dropped off or whether. And Ólafur, if you are here and you'd like to jump in, please do.
I am here. I am very sorry. I was a bit occupied. Just if there was a question for me.
So the question is on the layout of care homes in Iceland, and we were very struck with the image of this isolation facility that was used in Iceland and how homely it was and how contrasting to some of what we have seen in other countries.
Okay, actually, the thought with that was originally in the beginning, or in the second wave, in the end of last year and the beginning of this year, was that we needed the thought of that was to be able to gather from nursing home those vulnerable patients that were infected, and to reduce the risk of having to send them to hospital in those isolation rooms with those people, you know, where you're only alone and sick, and having staff that is unfamiliar to you and in those costumes treating you. Of course, we had to have our staff in those costumes, but we had the benefit of this 10-bed ward where people could eat together and watch TV together or play some games and discuss and so on. So that was a much more humane thing, I think. Now we have a different situation where most of the older population is vaccinated. So the risk in the nursing home themselves is not as large, but we actually have, of course, the problem of daycare patients that can't be home in isolation because of dementia, and older people that are somehow not able to be at home, maybe with a sick spouse or something. And we are actually opening this ward again tomorrow, under the same pretense, except maybe not as much, just to gather people from nursing homes, but older people in the community that need this because of their special situation.
Thank you very much. And I realized we were 3 minutes over out of only a 10-minute break, which is not great. So I will thank you so much for a fantastic session and learning. We will record this, we will share it, we will share the slides as well. And obviously, those of you who haven't studied in the report, I'd love to hear more about all this in the report as well. So thank you. A well-earned break. See you in about 6 minutes by now, so better stop. And thank you for all the speakers as well and everybody for all the